functions, urinary incontinence, decreased libido, and of course in females an increased incidence of UTI. Pseudomotor, we generally, when we examine a patient's dry skin and anhidrosis are common. Pupillary is one where I fail in detection impaired pupillary light adaptation. It's because I haven't put it into my practice, but we should actually do this. And we've had a wonderful talk previously, and actually we should do this so that to rule out the abnormalities in the pupillary reaction also. Now, screening is very, very important. As we always say, prevention is better than cure. So it has this rule that type 1 diabetics, the screening should be done at least annually, at least after 5 years of the diagnosis. And for type 2 patients, assess all patients annually. Now, this is so because many a times we get the patient at the time of diagnosis, they come with lots of diabetic ulcers. So these foot ulcers, so this is the reason why type 2 diabetics, they should be assessed at the first visit and then annually. And what type of assessment is to be done, we'll be seeing later on. Most common early symptoms when the small fibers are involved, pain and dysesthesias. Later on, when the larger fibers are involved, are the numbness and loss of protective sensation. And this loss is a risk factor for diabetic foot ulceration, which is not very common in our part of the country. Why screen for neuropathy? As I was telling you, prevention is always better than cure. And of course, education is the key behind the decreased incidence, what we want, the decreased incidence of foot ulcers. Now, DPN is symptomatic in up to only 50% of cases, and we lose the other 50% which are non-symptomatic. So it is our duty, the physician's duty, to find out about those patients who have asymptomatic neuropathy. And of course, the most painful symptoms are treatable if caught at the correct time. And the last point here, DPN is a marker for generalized CV disease. This is very, very important. And it has been found out that the 6-year follow-up of 169 diabetic patients with variable degree of neuropathy, 18% died, 37% developed foot ulcers during the 6 years. And if these patients had been screened, we could have avoided the development of foot ulcers. So neuropathy is a predictor of mortality in diabetic patients, a predictor of cardiovascular disease. A simple test can at least predict and prevent the untimely deaths and the morbidity rate in many of our patients. Now, the diagnosis and assessment is the next step, and the diagnosis of PDN is primarily clinical, based on a history of neuropathic pain and confirmatory examination findings. The clinical signs of DPN follow the same distal to proximal. We all know the distal to proximal pattern, and tests are very, very simple. There are several scoring systems which can be used, but the patients can be given this format when they are in the waiting area, and these are very, very simple. They just have to tick on it. And here is the summary of the most common tests used to assess neuropathy. The most common being the nerve conduction test here. The second is the neuropathy disability score, which I was talking about. So these are the two most common tests, and even easier tests are the simple tests in asymptomatic patients. This should be done, I think, in all our patients who come to our clinic. As the ADS says, a simple temperature or pinprick test along with the tuning fork and monofilament test. Now, this is very, very simple. A technician, a trained person in our clinic can do it. And this gives a lot of information about the condition of the foot neuropathy status of the patient. Of course, in symptomatic patients in our clinics, which is not very, very specialized, if not very specialized, we can go for simple but very informative tests like biotheziometer and Doppler test. So these are also, they give a lot of information about the status of the patient's feet. Now, the management of diabetic neuropathy, as the ADA says, it divides it into three. First is the prevention. As I said, prevention is of utmost importance, and this is why screening is done. The second is based on the pathogenic treatment. What is the pathogenesis behind it, whether we should give aldose reductase inhibitors, alpha lipoic acid, or vasodilators. And then third is, of course, the symptomatic treatment. The patient, the first in the symptomatic treatment is to aim for a stable. I lay stress on stable, and a fluctuating blood sugar is very, very bad. And as Dr. Mishra was discussing earlier, time in range is very, very a new concept, and it has come into practice. And to keep our patients' blood sugars in the time in range is very, very important for giving a better neuropathic status for our patients. And then it's not just a good HbA1c, the TIR is very, very important. And of course, then the pain, if the patient has pain, the symptoms should be relieved. Now, here the treatment is based on the stages of TPN. Simple staging, no neuropathy. Clinical neuropathy, if it is chronic, painful, burning, shooting, stabbing pains, acute painful, hyperesthesia is there, painless. This is one of the worst, painless with complete or partial sensory loss, and then the late complications like the foot lesions and neuropathic deformity if we have. So our treatment will be based on this. Now here the management depends. If there is no clinical neuropathy, remember to educate the patient. We can have simple educating videos running on a TV in a waiting room, so the patient is educated. Our patients are becoming very, very aware. The attendants are becoming aware of the pre-diabetic states. So similarly, they can be trained about diabetic feet. It is easy for them if they come to our clinics and they continuously see the videos. What is this test? Why it should be done? So in the no clinical neuropathies, of course, a good glycemic control is required everywhere. Education here is very, very important. Clinical neuropathies, management of symptoms, and prevention of foot ulcers. In all the other three, education is very important. A good glycemic control. Foot care is very important, and footwear again is very, very important. Not going into the details, we all know about it. And in other types of diabetic neuropathies, of course, the patient, we should take help from a neurologist, of course, so that a better treatment, the patient can get better treatment. Now, here is a simple algorithm by ADA, and I think this is the same algorithm which our own RSSDI follows. The type 2 patients with neuropathic pain, first and foremost is optimized glycemic control. And remember, it's not always insulin which is necessary. Even we have those wonderful oral anti-diabetic agents which work wonders in stabilizing the blood sugars. And just by adding a simple neo drug, the patient can give a stable and a better control than the tricyclic antidepressants, the anticonvulsants. So many like the SNRIs and SSRIs, the opiates and topical medications we have. So this is how the algorithm by the RSSDI, it helps us in the management of neuropathic patients. Now I was talking about preventive drugs. Prevention is definitely better than curing or the development of neuropathy. And here are three very, very important things. Methylcobalamin. Now this methylcobalamin is one of the forms of vitamin B12, and now this is very important because it is a cofactor. Here we can see previously I said the accumulation of homocysteine. So here methylcobalamin acts as a cofactor in the conversion of homocysteine to methionine, which helps in the methylation reaction of the myelin sheath. And so this if methylcobalamin is not present, and remember methylcobalamin is not there in natural in the vegetarian foods. So vegetarian people who are completely vegetarian or vegans, they lack generally their methylcobalamin levels are low, and they have to be given an additional capsule of methylcobalamin, which helps to a great deal in the development of neuropathic symptoms. So here methylcobalamin is shown to promote nerve regeneration or remyelination. It helps in the synthesis of methionine, as we've seen, which is associated with the biosynthesis of the myelin protein of the peripheral nerves. The second is the folic acid. It is known as vitamin B9. It is found in the natural foods, and of course the recommended dose of India is approximately 200 micrograms. It is found in a variety of foods, natural foods, and I think additional folic acid is not necessary if one is taking a healthy diet. The third is pyridoxine hydrochloride. It is also known as vitamin B6. It is again very important for the synthesis of sphingolipids for myelin, again for the myelin sheath. Then, so here is the simple cartoon which shows how these three, methylcobalamin, folic acid, and pyridoxine, they help in the forming the myelin sheath of the peripheral nerves. And this is again very important, alpha lipoic acid. See, this has a fourfold reaction in regenerating the natural oxidants, reduction in free radical mediated oxidative stress. It is a potent antioxidant and improves glucose and lipid metabolism. So combination of methylcobalamin, alpha lipoic acid, folic acid, and pyridoxine, if given to a patient, it helps a lot in the development of neuropathic symptoms, especially I've seen in pure vegetarian patients. So see, this is a cartoon of ALA and neuropathy, a wonderful, beautiful cartoon, what I was just talking about. This is a visual which has more impact on us. And the treatment algorithm for distal symmetrical polyneuropathic painful diabetic peripheral neuropathy, when we talk about once it has developed, we definitely when we give the regular painkillers which are safe in diabetics, and then we go in for the first choice, that is the pregabalin or gabapentin or the TCA, the duloxetine. So this is how we keep on fluctuating, and tramadol opioids are given, but not so commonly. So here the current guidelines which have been approved by ADA, FDA. The first line, if we talk about the ADA, the first line of drugs are the duloxetine and pregabalin. The second are the tricyclic antidepressants and the gabapentin. And we keep on juggling between these two. And I think very few of my patients are actually happy after giving any of these drugs. I mean, this remains a menace once it has developed, and they come to us with bad neuropathic markers, then nothing actually works completely. So talking about gabapentin is of course given, but because of its side effects, it is not so acceptable. I mean, it is of course given, but the more acceptable is the pregabalin, which is very, very potent, and this works very well if given initially, and up to a maximum of 300 to 600 of course is given during the daytime, and I prefer giving it in a sustained release form. And if the patient, the main complaint is drowsiness here with pregabalin, if the patient complains of drowsiness, I shift the time of giving the drug at around 6 in the evening, so that the patients don't have a drowsy feeling when they get up next day in the morning. And I have a lot of faith in this molecule for treating my initial neuropathic patients who have not advanced much. Later on, it remains a menace. So of course, research is going on in this field, because it is very, very disturbing for both the treating physician and the patient once the patient develops it in a full form. And we have several drugs which are coming up, and research is going on. Here we have a number of drugs still not in our basket. Still a lot has to be studied about the neuropathy, and I hope we get more better, more effective drugs, so as to remove this the menace from our basket. Thank you so much for your patient listening. Thank you, my friends.
Thank you so much. Thank you so much, Dr. Kapoor. That was a wonderful presentation. I have some comments, some questions for Kapoor madam.
Well, if there are some questions, it's fine. Otherwise, I'll make a comment later on.
Sure.
बोल दे अजय, बोल दे
सर, इससे अच्छा प्रेजेंटेशन नहीं देखे हैं सर सुबह से. So one of the best presentations, and the only thing which was worrying me was pregabalin का use जो हम लोग कर रहे हैं. And the last line on the pregabalin slide was the NNT required for 50% reduction is 5. So we actually benefit only 20% of our patients with pregabalin. But to all said and done, one of the best presentations. We could revise all our neuropathy part. And before your presentation, I was having a chat with Dandanya sir. You were talking with the phone, and thank you for such a wonderful presentation, ma'am. It's good to see you always.
Thank you so much, Adhir, for making my Sunday. Thank you so much, organizers. It's a wonderful
one thing. There are a
Yes.
lot of companies having combination of gabapentin and nortriptyline in the market.
Yes, sir.
How good are they, and how irrationally are they being used in the treatment of diabetic neuropathy?
So they are being used.
Why they are being used? They should not have been used.
They should not have been
Yes.
used, but they are effective. So up to a certain extent, they are effective. Patients, at least those who are very, very disturbed with the symptoms, they come back with maybe 10% relief. They say, I somehow sleep in the night.
There is a very good data on the combination therapy of pregabalin, dualoxetine, pregabalin, nortriptyline, and the data are that single drug is much better than the combination drug. Is the study name is only the combo drug therapy in diabetic painful neuropathy.
Yes, sir. But the thing happens that when you give a number of drugs, they generally leave out methylcobalamin, or somehow they leave. The compliance is bad. So it is being used, but all said and done, a pregabalin and nortriptyline are definitely much better.
And see, there are 3 things. We have 2 good drugs which are approved by US FDA. One is dualoxetine, the other one is pregabalin. The others are off-label use, isn't it?
Yes, sir.
Now, the 2 different class of drugs. One is anticonvulsant group, pregabalin. The other one is SSRI group, is dualoxetine. Dualoxetine has got 2-3 uses as far as indications are concerned. Diabetic painful neuropathy is one. As an antidepressant is the second. Urinary incontinence is another indication for dualoxetine. So there are 2-3 good indications for dualoxetine. On the other hand, pregabalin. Pregabalin causes sedation, as you rightly said, and it's an anticonvulsant. So it has got a lot of drug interactions, as we see with even gabapentin. Even it causes edema, fluid retention, if you use in the doses which you recommended as a therapeutic dose. Now, which one to use where is a very, very important area. You cannot use combination because it's not helpful. That is for sure. And we have enough data. There are not 1 or 2 studies, there are multiple studies, meta-analysis for combination therapy. Now, you have a class of patients who are young and who are working and who have diabetic painful neuropathy. Dualoxetine is a better choice because the chances of urinary retention is less, the chances of sedation and not going to work is less, and feel-good factor as an antidepressant is better with dualoxetine. Whereas elderly population where sleep deprivation is more, where chances of urinary retention with dualoxetine is more, pregabalin is a better choice. So I think that is how you should actually categorize different class of drugs as far as diabetic painful neuropathy is concerned. And you can use good doses of dualoxetine. You can start with 20, 30, 40, 60, 90. You can go on, but never prescribe a combination of drug. That is not recommended. You can give a dualoxetine along with methylcobalamin, as you rightly said, in vegetarians, and even Indians on metformin have some data with B12 deficiencies. So that way you can put different categories of drugs for different patients. So this is a very,
but
very
clinically speaking, pregabalin and nortriptyline combination, I've been using it a lot, and we are seeing a lot of good results with this.
Exactly. If you use a single drug, also you will see a good result. You don't need 2 drugs at one time. You have to use a single drug in a good dosage.
Point well taken. We can use it as a single drug, pregabalin 75, and then we can use other drugs also in combination.
See,
but what I'm trying
75 is not a therapeutic dose, Ajay.
Yes.
Pregabalin 75 is not a therapeutic dose. You have
but the starting, it has to be gradual and very slow. We cannot
Yes.
start with 150 or 300 because that is going to cause lot of sedation.
Yeah, agreed. Definitely. So start slowly.
I usually start with 75 and then up titrate to 150.
Perfect.
And we see good results with, and I personally speaking, clinically speaking, I see good results with pregabalin and nortriptyline combination a lot.
No. You use only nortriptyline. Don't use pregabalin. Use only nortriptyline. You will get very good results.
Yeah, but I'm a big fan of duloxetine. We are using duloxetine a lot in our center.
Yes. Definitely. Yes. It's a very good drug. It's a drug which has been approved. Cymbalta is the international name.
Yeah, and we can also give it in the morning time.
Yes.
Yes, I give it after breakfast every day.
Young patients give dualoxetine. elderly patients avoid dualoxetine.
Yeah, and start pregabalin. I'm a fan of pregabalin, not triptan combination, but henceforth from tomorrow onwards, I'll just try to split the dose and see and split the medicines and see how does it work.
References I can send you. Very good data. They have done this research in a very huge number of patients. It's only in our country where it has been promoted. There is no recommendation for combination therapy.
But India, everything is allowed, sir. India, everything is allowed. Without safety data, we have started using Vilda OD.
Yeah. No, now they are coming up. I mean, Novartis is possibly has done some studies of bio.
Yes, but Novartis is giving this drug only for India. No other country has allowed it. Novartis सिर्फ India के लिए बना रहा है OD combination because they know they can push it through the market, and once it is there in the peripheries, nobody can stop it.
नहीं, लेकिन Novartis International has an eye on whatever they do in India as well. They cannot...
3 days back, we were there in the advisory board. Dr. Bansi Sabu was also there, and we were very worried. Why Novartis, after 10 years, suddenly has decided to come with a OD formulation only for India?
Yeah.
Why not other countries? So let us be very careful, and this is the right platform to spread this message that OD, Vilda, please be very careful in terms of the hepatotoxicity it might cause. And we rarely do the LFT or SGPT of our patient when we start prescribing them on drugs. None of us do it actually. Nobody does SGPT or LFT of the patient before we start vildagliptin. So Vilda OD combination should be spared actually till we get some more safety data.
Ajay, Nupur is a very good prescriber of Galvus, let me tell you. I would request her to do lipase and amylase in patients who are taking vildagliptin for last 6 months.
Yes.
Invariably, you will find 2 to 3 times abnormally raised lipase and amylase is in patients.
I have 13 patients, sir. I have 13 patients on vildagliptin with raised amylase lipase. We stopped Vilda and their amylase lipase went down. They did not have any features of pancreatitis.
Yeah.
50, if you give 50 to 100 is not recommended. 100 OD is not recommended.
Yeah, 100 OD to start karna hi hai, madam. Abhi 100 OD we are not starting at all unless we get some safety data. But with 50 BD also I have 13 cases recorded who increased their amylase lipase without any pancreatitis.
मेरे पास तो
we
बहुत है.
withdrew the drug and the amylase lipase went down.
And let me tell you, these are the patients who complain of excessive bloating, excessive gas formation.
Yes.
That is all they complain.
Yes.
But there
are only 13 patients, ma'am. I have seen a few thousands of them. So there are only 13, nothing much to it.
You take breakfast at the right time, there will be no bloating.
And I'm telling you, because these are few things which are not been addressed with these molecules.
Very correct.
But I'm extremely, to be very frank, I'm extremely worried by this 100 milligram OD formulation which has come in the market. It will be used left and right by the physicians everywhere, especially in semi-urban areas and rural areas. And we'll be getting more cases of liver injuries in future.
अजय, तेरे एक बात बताता हूँ. तो खाली vildagliptin 100 मिलीग्राम का बोल रहा है ना? कि कंपनी वाले vildagliptin 100 मिलीग्राम और SGLT रीमोग्लिफ्लोजिन 100 मिलीग्राम का कॉम्बिनेशन लेके आए हैं. और बहुत ज्यादा स्ट्रॉन्ग प्रमोशन में कितना माल मांगता है तेरे को पूछ लिखने के लिए. समझा क्या? तो क्या है ना, ये अभी बहुत जोर से आने वाला है और ये बहुत लफड़े करने वाला है दोनों को दोनों.
But it's going to increase the comorbid conditions बढ़ते जाएंगे सर. Liver injury बढ़ेगा. और people have already started using OD combinations. Good physicians, senior physicians have already started using OD combinations.
ठीक है, करने देना यार. तो
चलो, Jagnany sir will take care of that, sir.
Yeah. Thank you so much, Dr. Nupur for her excellent presentation and wonderful discussion. 2 things to point out. एक तो जो आपने hepatic और pancreatic injury बोली है वो तो है ही है. साथ में vildagliptin also causes increase in LV volumes.
Yes.
So
yes.
Practically, I have stopped writing vildagliptin.
तो तेरे को स्पॉन्सरशिप मिलेगा नहीं मीटिंग के लिए, ऐसा बोल मत खुला. नेक्स्ट टाइम से मीटिंग होगा नहीं.
कुछ भी बोल सकता हूँ मैं. आज के प्लेटफॉर्म में कुछ भी बोल सकता हूँ.
वर्चुअल में कुछ भी चलेगा.
ये फार्मा पीपल नहीं है यहाँ पे कोई भी.
नहीं, वर्चुअल में चलेगा.
1 सेकंड, डॉक्टर छावड़ा का आज अवार्ड बच गया है. अगर ये बाद में देना रहता है तो नुपुर मैडम को मिल जाता है ये, क्योंकि हर प्रेजेंट इज बेटर.
आज सारे मिलकर मेरे पीछे पड़े हैं.
नहीं. It is very nice presentation, ma'am. Very nice presentation.
Definitely,
We are already very late. बड़े
हाँ,
आप.
very.
With this, we would like to present the uh, sorry, just a minute. We'd like to yes, present the certificate of faculty to Nupur madam, and with that we move to our last but one talk. Dr. Arun Kedia from Raipur, consultant physician and head of ICU at Life Worth Hospital with experience of more than 10 years, life member of various societies, president API, district coordinator to RSSDI, and various clinical trials and research with publications and author in chapter and books. We will be talking on LADA, how do we move from OHA to insulin. With that, I would request Dr. Kedia to kindly take over and present his talk to us. Over to Dr. Kedia.
Good evening, everybody, and especially thanks to Dr. V K Jagnany sir for giving this opportunity to be a faculty today for the CARDIABCON at Ranchi. So even in the COVID pandemic time, we are all here on a Sunday evening discussing some beautiful issues, and I was extremely happy to see that there were two different issues that we were listening to, and those were both related to psychiatry. And it was a wonderful mixture of cardiology, diabetology, as well as psychiatry today. My task in the next few minutes is to discuss on uh, another important aspect of diabetes, and that is the latent autoimmune diabetes of the adults, which is abbreviated in the form of LADA, and we all know it as LADA for the last 40 years. This term is not new, but unfortunately, not much work has been done on this particular aspect of diabetes. And it is one of the neglected aspects of diabetes because it's one of the diabetes which falls as a hybrid diabetes between type 1 and type 2 diabetes. We all know diabetes itself is a very, very heterogeneous disease, and classification of type of diabetes has been always very tough ever since we have been learning the science of diabetes. So LADA is basically a subgroup of diabetic patients who develop phenotypically type 2 diabetes, but with time they have markers of islet autoimmunity and they proceed on to requirement of insulin within 2 to 3 years. So this is the subgroup that is initially was thought to be only as type 1 diabetes, but then there were several debates. Until date, this LADA term has not been able to find the right place in the field of diabetes. Now, this LADA is not very common. If we see the data of type 2 diabetes patients, almost 10 to 12% of type 2 diabetes patients would eventually fall into the category of LADA. And it has also been found to be the most common autoimmune form of diabetes in the adults, more than it is adult onset type 1 diabetes. So if you have 10 patients of adult onset type 1 diabetes, then probably you will have 100 patients of LADA. So that is why it is very important to understand what is LADA and how the treatment of LADA goes about. So this debate of placing LADA in the classification of diabetes will keep on going. So if we see the spectrum of type 2, if we see the spectrum of diabetes overall, we have on one hand autoimmunity and on the other hand insulin resistance. Now this insulin resistance is a driver to type 2 diabetes and autoimmunity is the driver to type 1 diabetes. So if we plot all these diabetes patients against these two graphs, then you will have something like this, where we have lots of patients with having overlapping diabetes syndrome. So if we have the extreme of insulin resistance, which would be signifying a patient of type 2 diabetes, and we have extreme of autoimmunity where we have type 1 diabetes, then in between you have between type 1 and type 2 diabetes is the LADA. So if we have to place LADA in the spectrum of diabetes, then this would be the position of LADA. So what is LADA? So as I said, LADA is adult onset diabetes with shared features of type 1 and type 2 diabetes. It is a diabetes in which the patients do not require insulin initiation right from the beginning, but eventually they'll end up requiring insulin within 2 to 3 years. The patients are associated having immunogenic markers associated with type 1 diabetes, and these are primarily the anti-GAD antibodies. However, you have other antibodies are also found to be present in LADA. And LADA accounts for 2 to 12% of all patients with adult onset diabetes. So that's what I said, that LADA is not a rare entity. So if we go for the diagnostic criteria for LADA, this diagnostic criteria was proposed in 2005 by the Immunology of Diabetes Society, whereby they proposed 3 criteria for LADA. That was adult age of onset more than 30 years, presence of any islet cell autoantibody, and absence of insulin requirement for at least 6 months after the diagnosis of LADA. So if we consider this particular diagnostic criteria, again, there was a lot of debate, and ultimately this criteria was not accepted. And finally, in 2020, the international consensus on LADA, they highlighted that all these clinical characteristics may help to identify LADA, but they cannot categorically define LADA. Now, the reason is the age is different in different studies. There are certain studies where the inclusion criteria for age has been 30 years. There are certain studies where 35 years has taken. And in China's studies, they have taken age to be around more than 18 years. So there is a heterogeneity with regard to the classification with regard to age criteria. Then presence of islet cell autoantibody. Again, you can have false positive islet cell antibody. You can have transient islet cell autoantibody. So all these patients, again, are not rightly categorized as LADA. Third, absence of insulin requirement. So if you have a patient of LADA who presents with some acute infection, then probably he requires insulin right from day 1. So that is again, a patient who has been initiated right on insulin will be categorically, he will not be put into LADA category. So all these fallacies of this particular classification finally moved this classification out into the from the picture, and now we have clinical criteria for defining LADA rather than we have the diagnostic criteria for LADA. So coming to the epidemiology, as I said, LADA is not a rare entity. The UKPDS showed incidence of 12%. The NIRAD group showed 4.5%. Hunt group showed 10%. Then we had Action LADA group, which showed 9.7%. And then LADA China showed 5.9%. Now, again, you see that there is a vast variation. And this, again, is because of the criteria, the inclusion criteria for patients, and the type of autoantibodies that were detected and the level of autoantibodies that were given as cutoff. So all these led to a different prevalence in different study groups. Now, if we have to study the pathogenesis of LADA, if we have to think it as a hybrid of type 1 and type 2 diabetes, then on one hand, we have insulin resistance working on, and on the other hand, we have genetic susceptibility with autoimmunity. So if we have a patient who is more prone to type 1 diabetes and he has genes which are susceptible to cause autoimmunity, upon that, if we have some lifestyle factors which initiate the autoimmune reaction, then these patients develop islet autoimmunity and they ultimately land up with LADA. On the other hand, if we have patients who are prone to develop type 2 diabetes and they have some ongoing inflammation due to the visceral adiposity, then these patients, because of some lifestyle factors and ongoing inflammation, can develop insulitis and develop islet autoimmunity, which can proceed on to LADA. So the exact pathogenesis is not known. We have certain genetic susceptibility studies that have been done. We have markers of HLA. We have certain genes like INS and PTPN322. Then we have genes of type 2 diabetes, that is TCFL7L2, which have been found in LADA patients. So this makes, again, LADA a very, very heterogeneous clinical condition. So this is what I was trying to tell you, that if you have a genetic susceptible patient and if you develop a trigger due to autoimmunity, then they develop insulitis leading to insulin deficiency and cause LADA. On the other hand, you have low-grade inflammation due to visceral adiposity, which can lead to insulitis and impaired insulin secretion, increased insulin resistance, and again can lead to LADA onset. So this is how so far we have been knowing about the pathogenesis of LADA, and there have been a lot of studies going on, and there have been a lot of defining genes that have been found on for differentiating type 1 diabetes patients from LADA. So if we think of the general characteristics of LADA, then patient's age again would be somewhere around beyond 25 to 30 years. There may be a family or personal history of autoimmunity. Compared with patients of type 2 diabetes, they have a lower incidence of metabolic syndrome, lower insulin resistance, lower body mass index, and lower blood pressure. They have normal HDL compared to type 2 diabetes patients. There is no disease-specific difference in cardiovascular outcomes between LADA patients and type 2 diabetes patients. The C-peptide, which is the hallmark for these patients, their levels fall more slowly than it falls in type 1 diabetes patients. There is positivity for autoantibodies, especially the anti-GAD antibodies, which is the most sensitive marker. But there may be other autoantibodies like IA antibodies and the antibodies to zinc transporter. And these patients classically do not require insulin at the onset of the disease. So this is what are the general characteristics of LADA. And if we have to consider LADA as a hybrid between type 1 and type 2 diabetes, then this diagram explains very well. On one hand, you see that the younger the patient, the likelihood of type 1 diabetes, and as the patient's age advances, it is likely to be type 2 diabetes. If the patient is non-obese, then it is likely to be type 1 diabetes, and with obesity, you have more and more type 2 diabetes. Similarly, if you have more metabolic syndrome, it is likely to be type 2 diabetes. With lesser metabolic syndrome, you have type 1 diabetes. If you have more antibody, it is likely to be type 1, and with LADA and with type 2, the antibody levels keep on decreasing. And similarly, if you see clinically, the insulin requirement in type 1 diabetes patient is right from day 1, which doesn't happen to be with LADA and is usually very late with type 2 diabetes patients. So this is in a nutshell, which explains that LADA is a hybrid of type 1 and type 2 diabetes, and clinical heterogeneity exists for LADA patients. And if you see the clinical differences, as I said, that there is a difference in the age, the presence of insulin resistance, the time to requirement of insulin, the presence of autoantibodies, and the insulin level at diagnosis, they all can help you to differentiate between type 1, type 2, and LADA patients. Of course, it may not be a very, very clinical, clear demarcation, but we can categorize patients into suspected LADA or suspected type 2 diabetes patients. So moving on to then, how do we diagnose LADA? So we do not have diagnostic criteria to define LADA patients. So we have this consensus where we have certain criteria for clinical screening. And if we have these 5 criteria, that is age of onset less than 50 years, acute symptoms before the diagnosis, BMI usually less than 25 kg per meter square, personal history of autoimmune disease, and family history of autoimmune disease. Now, out of these 5 features, if you have any of the 2 or more features clinically, then you can suspect LADA in such patients, and these patients would then be subjected to detection of autoantibodies to confirm whether these patients have or do not have LADA. So these are the clinical screening tool, and various studies have shown that this clinical screening tool has been found to be a very, very nice tool to suspect a patient of LADA clinically. So once you have a suspicion of LADA, then you go for GAD antibody screening, and if the patient turns out to be positive, then the next test to be done is a C-peptide level, so as to detect what is the level of C-peptide, which would be deciding factor for the treatment of these patients. Now, if the patient doesn't have GADA antibody, then likely that this patient would be type 2 diabetes. But if you have a clinical suspicion for LADA, then you can go for other autoantibody tests, which are much more costlier than the GAD antibody. So you can go for screening for IA2A antibody or zinc transporter 8 antibody. And then subsequently, if those are positive, then again, you can label these patients as LADA and go for serum C-peptide levels. So does the diagnosis of LADA affect the outcome? So we know that LADA patients often have a better lipid profile. We have seen they have a lesser metabolic syndrome, lower blood pressure. They have lower body mass index. They have some patients with low titer antibodies. Some patients have a high titer antibodies. But no studies have shown any decreased macrovascular complication risk in patients of LADA, and there has been no difference even in the microvascular complications except maybe nephropathy. So in a nutshell, even with LADA diagnosis, the difference with macro and macrovascular complications are not there. And so these patients need to be treated as diligently as we treat other type 2 diabetes patients. Of course, LADA also has a higher prevalence of other autoimmune diseases, which might affect the outcome. And especially these patients have certain group of autoimmune diseases which are likely to be present. And these autoimmune diseases that are linked to LADA are thyroid autoimmune diseases, which could be Graves' disease, or it could be Hashimoto's thyroiditis. There could be pernicious anemia, celiac disease, Addison's disease. There could be autoimmune hepatitis, vitiligo, myasthenia. So all these antibodies, all these GAD antibody positive patients clinically may be also screened for such autoimmune diseases and must be looked on and followed on for other autoimmune diseases. Now, the next question comes, does GAD antibody titer matter? So there have been studies where patients have been categorized based on the antibody level. And there are studies which have shown LADA type A and type B, where type A patients resemble more of type 1 diabetes patients and type B resemble type 2 diabetes patients. The patients who resemble type 1 have more GAD antibody, and type 2 diabetes resembling patients have lesser GAD antibody. But what we need to remember is that we do not still have a cutoff for criteria for diagnosing whether the GAD antibody is high titer or low titer. In most of the studies, 10 international units has been taken. But as of now, we don't have any evidence to differentiate as a high titer or low titer. More important is that LADA heterogeneity is also linked to these autoantibodies, and we have seen that the GAD antibody has ethnic differences. You will see GAD antibody much more in the Caucasian population than in the Chinese population. So that is why if you see this prevalence of LADA in the LADA China study and the Korean studies, the prevalence is around 5.7 to 8%. Whereas in the NIRAD group and in the other European studies, Italian studies, they found that the GAD antibody levels were high, and there the prevalence was to the tune of 12 to 13%. Another important thing is that if you have a high titer GAD antibody, then you have more likelihood that you will have other antibodies also, and these patients may have multiple autoimmune diseases. So GAD antibody has significance in terms of that if you have a high titer, then probably these patients are likely to have more number of autoimmune diseases. Second, they have also found that the GAD antibody epitopes also account for heterogeneity, and you have different types of epitopes of GAD which are linked to resembling patients of type 1 and type 2 diabetes. And if you want to go into details, there are various papers where they have subjected different GAD antibodies epitopes, and they have found that certain epitopes resemble more to type 1 diabetes patients, or certain epitopes they are more associated with type 2 diabetes patients. So there are certain risk factors which have been defined for the loss of beta cell function in LADA, and these are the number of autoantibodies, the high GADA antibody titers, the lower BMI, the high risk HLA genotypes, especially the ones which are associated also with type 1 diabetes. And of course, the sulfonylurea treatment after the diagnosis of LADA would also be one of the factors for rapid loss of beta cell function. So this is why very important that if you have any of these factors, then these patients are likely to have more rapid beta cell loss, and they need to be treated much more aggressively. So coming to the treatment of LADA, because we do not have any algorithm for the diagnosis of LADA, we do not have any particular classification stage at which we put LADA. So the goals of treatment for LADA would be metabolic control in terms of blood sugar, in terms of lipids. And at the same time, we need to preserve the beta cell function so as to produce insulin as much as possible intrinsically. So there have been various interventions in LADA. So the foremost and most important is the lifestyle modification, which we universally apply to all the patients of diabetes. After that, there have been studies on insulin sensitizers in the form of metformin and thiazolidinedans. But of course, the studies on these drugs have been very, very few. Of late, DPP-4 inhibitors have been found to show some protection on beta cell survival, and probably we need more larger studies for proving this, that the DPP-4 inhibitors would be useful drugs in LADA. Very few studies on GLP-1 receptor agonist, especially the dulaglutide, has been shown to have a preservation of beta cell function. SGLT2 inhibitors still under research for LADA. We do not have any evidence of usage of SGLT2 inhibitors in LADA. And insulin would always be the mainstay of treatment, because most of these patients would proceed on to insulin requirement after maybe 6 months to 2 years. Immune interventions again are under research, especially vitamin D has been linked to be deficient in LADA patients. And there have been studies where they have found that if you correct vitamin D deficiency, then the chances of LADA progression is less. There have been other immune interventions like the alum incorporated GAD have been studied, but as of now, we do not have any recommendations for immune interventions in such patients. So what are the various points to consider while considering the treatment of LADA? So LADA patients, we know they have detectable C-peptide levels at diagnosis, and that is what differentiates them from type 1 diabetes patients. In case of treatment failure, we need to keep on repeating the measurements of C-peptide to find out whether these patients would need insulin. And C-peptide measurement should drive the decision-making process for the choice of LADA treatment. So the LADA treatment cannot be fixed. It has to be a personalized algorithm. And this is what the International Consensus 2020 has proposed, that you categorize the patients into 3 based on C-peptide level. So you have a category where C-peptide is less than 0.3, and then you have a category where C-peptide is more than 0.3 and less than 0.7 nanomoles per liter. So if you have C-peptide levels less than 0.3, then these patients would straightforward move to insulin. But if you have patients in between 0.3 to 0.7, then you can use metformin for the initial few months and then reassess these patients every 6 months. If you have any of these patients with high risk, especially the established atherosclerotic cardiovascular disease or CKD, then we apply the ADA or ESD guidelines of 2021, and we go by these guidelines, which we are all familiar now. Now, if these patients are in without established atherosclerotic cardiovascular disease, then we can use DPP-4 inhibitor, or we can use GLP-1 receptor agonist. We can use SGLT2 inhibitors or thiazolidinedans. What we need to remember is avoid using sulfonylurea at every cost. So there has been a strong recommendation not to use sulfonylurea group of drugs in these patients. So the key points that we have learned today is that adult onset autoimmune diabetes encompasses a wide spectrum of heterogeneous genotypes and phenotypes, which range from classic adult onset type 1 diabetes to latent autoimmune diabetes in the adults. The heterogeneity of LADA arises from its definition as being present in any adult with diabetes who does not require insulin, but is positive for any islet autoantibody, regardless of the titer and number or epitope specificity. The heterogeneity of LADA manifests in different clinical phenotypes, ranging from prevalent insulin resistance to prevalent insulin deficiency. Although patients with LADA are leaner and have healthier lipid and blood pressure profile, but they have no difference in cardiovascular outcomes against patients with type 2 diabetes. There is extensive heterogeneity of adult onset autoimmune diabetes, and particularly LADA, which makes it difficult to determine a priori algorithm for treatment. And the successful treatment of adult onset autoimmune diabetes will require a personalized medicine approach. So to summarize, the identification and treatment of LADA poses a significant challenge for the physician. And in India, especially where we do not have any access to doing antibody tests, or where we find most of the patients unaffording for antibody tests, LADA is often missed. Therapeutic strategies aim for metabolic control and preservation of residual insulin secretory capacity. Within LADA, C-peptide value is a proxy for beta cell function, and it will drive all the therapeutic decisions. And endotype heterogeneity within LADA implies a personalized approach to treatment. So with that, I thank you all, and we know that insulin is the mainstay of treatment of LADA. And in this centenary year of insulin, I dedicate this talk to none other than Frederick Banting, who has been the man behind insulin discovery. So I thank you all for a patient listening, and I would be happy to answer your questions.
I have a question, Dr. Kedia.
Yes.
Since we say we understand that the durability of OHs is less here in LADA. So why do we talk of using OHs or sulfonylureas even in primary stage, maybe for 2-3 years in LADA? Why not go straight forward to insulin?
So the problem is that LADA has to be suspected first in a patient, number one. Number two, many a times we are not able to diagnose these patients correctly. And that is why when these patients present to us, they look more like type 2 diabetes patients. And that is why these patients usually will require, they usually require OHA at the time of diagnosis and for initial few years. Only when we see these patients for follow-up and we see that they have a rapidly declining beta cell function, and in certain patients where we are able to do autoantibody tests, then only we suspect these patients to have LADA and we can start considering insulin treatment in these patients. But most of these patients will present like type 2 diabetes patients, and that is why we do not initiate insulin right at the diagnosis for these patients.
And we talk generally we should go with sulfonylureas. So what is
sulfonylurea? Usually, if you have a patient who is lean, if you have a patient who has rapid onset of symptoms of diabetes, and if he has a clinical suspicion of LADA, then sulfonylurea should be avoided in such patients.
Right. So is it okay to use SGLT2 inhibitors or DPP4 or AGIs in this patient?
Yeah, if these patients, the recommendation is that most of these patients would require metformin to start with. And if the patients are not controlled with metformin, then you can use any of these add-on drugs except sulfonylurea. But for how long these drugs will preserve beta cell function is not yet known. And different patients have different phenotypes, and they would present to you differently with regard to their beta cell function. So the whole research now is on which drugs would help to preserve beta cells. And that is why there's been a lot of research going on with the gliptins.
Okay. Comments from Chavda sir and Dr. Dhandania sir, Kapoor madam. Any other comments? Any questions?
No, sir, that was an excellent presentation. And thank you for enlightening us again regarding LADA. And the questions asked by Dr. Jagnany was very, very pertinent. The use of sulfonylureas and why not directly start insulin, because they don't require insulin in initial phases at all. And the different phenotypes, they actually also help us most of the times in identifying LADA cases. And in our Indian scenario, especially in our areas in Ranchi, Jharkhand, we see a lot of LADA cases. I see a lot of LADA cases, and ultimately they require insulin. And initially managed with oral hypoglycemic, but they tend to require insulin very, very early in their stages of diabetes. Excellent presentation, sir. Very nice. Thank you so much.
So I think if we have a provision for a registry of LADA patients in India, then probably we'll have get the true prevalence of LADA in India. There have been very, very few studies that have been done in India. And probably one of the reason is unavailability of antibody tests or unaffordability of most of our patients.
Exactly, sir. Exactly.
Kapoor madam, you want to say something?
So what you said, very well explained. And I think the unavailability is one issue, and the unaffordability is also the second issue. Tests are very costly. Yes. So it's the clinicians' suspicion of thinking about LADA is the main behind diagnosing someone as LADA. That's true.
I think C-peptide measurement will help us to guide.
Yes.
And C-peptide is not a very costly.
Not very costly.
We are doing in our labs. Yeah, we do it on our labs.
I also do very routinely from patients, especially the young diabetic patients.
Yeah. Young diabetic, lean and thin diabetic, we usually do it on the second visit, not on the first visit, because of the glucotoxicity which they have. On the second visit, by that time we usually control the blood sugars, and we do C-peptide, and then eventually we guide them according to the diagnosis. Yes.
So ideally, C-peptide should be done when the blood glucose is between 120 to 160 milligrams per deciliter.
Yeah.
So,
but I've been using C-peptide in a lot of my patients, and especially lean and thin patients, young patients, wherever I have a doubt. And since it's available in my lab, so it's become quite easy for us. And C-peptide is one of the best investigations in recent times, which is helping me in my clinical practice and to earn me some money as well. Yeah.
It actually ensure and it emphasizes the patient also tends to understand that what is my
Yes.
condition, why am I being given insulin. So they
Yes.
actually adhere to the therapy of insulin once they see the level of C-peptide.
I think
Whenever we do
doing
C-peptide,
C-peptide,
we just yes, sir, please go ahead.
yeah, I was just saying that once you have a documentation of C-peptide, it's very easy to convince the patient to consider insulin as a therapy. Otherwise, the patients will keep on moving from one doctor to the other. So once you have a documentation that the C-peptide is low, and then we explain to the patient what is C-peptide, I think 70 to 80% of the patients would understand and would adhere to insulin therapy.
Yes.
So
I
I
do
think
use
doing C-peptide levels would be a very, very sensitive and sensible way to proceed on to clinic and do a right management of patients.
Yes, sir. Personally speaking, even if we do a C-peptide and you just explain it to the patient कि आपके शरीर में कितना इंसुलिन बन रहा है और आपको कितने बाहर से external support की जरूरत है. Even a layman coming from a semi-urban area or rural area understands this, and it's very easy for us, and it helps in adherence and compliance as well. So yes.
Thank you so much, Dr. Kedia, for your excellent presentation on a novel topic in the sense, not much talked about it. So it was nice of you to choose this particular topic. Thank you so much. So if you are willing, we are a little late, about 15 minutes from session, maybe half an hour, I should say. So if you all are willing, we can have one last session. Otherwise, we can call it our day. Should we have that session?
Yeah, you can go ahead.
Thank you.
Yes,
Thank
yes,
you
why
so
not?
much.
Please go ahead.
Thank you so much. So before moving ahead, let me present the certificate of faculty to Dr. Arun Kedia. Thank you so much for your presentation. And with that, we come to the last topic of the day, and that is management of diabetes and hypertension. Just like to summarize in few lines, probably one single slide. Well, we have these drugs with ourselves in management of diabetes and hypertension: biguanides, metformin, probably used in practically all patients. We should be careful in patients who are a little sick because it can lead to lactic acidosis. So we should follow sick day rule if there is some situations like that, and avoid metformin. Otherwise, it's a wonderful drug practically in all situations. SGLT2 inhibitors are probably the treatment of the R in management of diabetes. Once again, it should be avoided only in situations of dehydration. Otherwise, probably it's safe in all situations if eGFR is more than 30. DPP4 is one of the wonderful drugs which doesn't hit the beta cells directly, so it has its own place and I guess it should be co-prescribed with SGLT2 inhibitors to avoid urinary tract infection. SGLT2 inhibitors are also being used in heart failure even without diabetes. GLP-1 receptor agonists are another wonderful molecules, but injectable and little bit costly. So that's an apprehension with this particular molecule. Otherwise, as an anti-diabetic agent, it's wonderful. Alpha glucosase inhibitors, the acarbose and voglibose, are the drugs which will reduce the glycemic load into the circulation and excrete the glucose by competitively inhibiting the absorption of glucose into the system, and therefore it will be a wonderful molecule by reducing the load in the blood circulation. Thiazolidinediones are wonderful insulin sensitizers. Only issue with this is it can lead to osteopenia and fluid retention, so it should be avoided in patients of heart failure or hypertension, or where we suspect that it can lead to fluid retention and we do not want that, should be avoided. Sulfonylurea, though, is a wonderful drug, has been used since ages now for a long time. Newer drugs are good ones, but in advent of the new medical therapy in diabetes, sulfonylurea has gone down the list. Though it is a preferred drug if economy is the concern, non-sulfonylurea secretagogues like repaglinide are talk of the time, and they are being used in present scenario, specifically in patients with renal involvement, and patient is reluctant to go on to insulin therapy because of their short action, short duration of action. Coming to the hypertensives, thiazide type diuretics, the hydrochlorothiazide and chlorothiazidone should be practically be written in every patients of hypertension, unless and until it is leading to electrolyte imbalance. Calcium channel blockers, as we know, should be used along with thiazide diuretics because they are the drug of choice in Asian patients. If the patient is diabetic, the choice is also to use ACE and ARB. So a combination, maybe low dose of more than one drug should be preferred, maybe thiazide, CCB, and ACE or ARB, specifically if the patient is diabetic, but ACE and ARB should not be co-prescribed. Loop diuretics becomes a choice in patients of failure, or sometimes it is co-prescribed with thiazide diuretics when we are unable to get the desired result in terms of management of hypertension. Potassium sparing diuretics are being used in heart failure patients, also in uncontrolled hypertension. Beta blocker is a drug of choice in younger hypertensives or in patients with cardiac involvement like heart failure or ischemic heart disease. Alpha blockers are used if the patient is having some prostate involvement along with hypertension, or if we are unable to achieve the antihypertensive control using above drugs. Similarly, central sympatholytics are used in renal patients more so, or in uncontrolled hypertension. Finally, potassium channel activators are being also used sometimes, and vasodilators vasodilators are being sometimes used specifically in post cardiac surgery in some patients, though not very commonly used. So this was a little bit summary, like some of the medicines or various drugs which are being used in diabetes and hypertension. And with that, I guess we can end today's talk, and that was the last session of the day. So any questions, or otherwise we can end the session. So if there are no questions, we will just move on to the, we would like to thank our organizer, our co-partners, the academic partners, also present the certificate of faculty to our chairpersons, Dr. Birmani sir, Dr. N.K. Singh sir, and Dr. R.K. Mishra sir. So with that, we would like to end the session for the day. Before ending, we must thank God. Karpur Gaurang Karunavatarang Sansar Saram Bhujagendra Haram Sada Vasantang Hridayar Vande Bhavam Bhavani Saitam Namami. In this month of Shravan, we pray to Lord Shiva to bless us. Let's keep safe. So with that, I would like to thank all the delegates, all the faculty for being here. Thank you so much.
Thank you, Jagnany sir. Thanks a lot, everyone. Please be safe. Good night,
Thanks,
Shubhra.
everybody.
ख्याल रखें अपना.
Thanks, everybody. And it was a wonderful evening.
I must thank all the delegates and all the faculty members for being here, sparing their time on a Sunday evening. Thank you so much.
Thank you, Dr. Jagnany. God bless you.
Thank you so much. I may request delegates can leave. We would like to have all of you once again on 15th of August for another interesting session. We will have a whole day session on that day. We'll share the link with you all. Thank you so much once again.